Welcome to Dis Explainer, where we're going to do something highly practical and absolutely crucial. We are going to translate a critical patient simulation into a clear, high-stakes formal nursing handover using the globally recognized ISO bar structure. If you've ever felt completely overwhelmed by a complex patient presentation, where honestly it seems like multiple things are going wrong at once, this is exactly what you need. All right, let's dive right into the file for Jaxson Miller. We're going to frame our entire analysis today as an urgent, real-time clinical briefing. Imagine you are receiving this exact patient right now, and the clock is ticking. You need the vital information, and you need it structured perfectly so you can act immediately. To handle this without getting overwhelmed, we're going to use this agenda as our ISO bar briefing outline. Identify and situation, background, observations and assessment, the deterioration event, and finally, recommendations and priority actions. Okay. Kicking things off with Section 1, Identify and Situation. Let's establish the stakes. So we're looking at Jaxson Miller. He's 31 and he's just developed some severe acute symptoms. We're talking syncope, basically fainting, along with severe hypotension and tachycardia. But here's the real kicker. His presentation is pointing to two overlapping, incredibly life-threatening conditions happening at the exact same time: a pulmonary embolism and a severe electrolyte crisis. Moving on to Section 2, the B in isobar, background. Because this isn't happening in a vacuum, right? Jaxson is on post-op day 10 for bowel resection due to Crohn's disease. He's got an active ileostomy plus a PICC line in his right arm for antibiotics to fight off a wound infection. And we really can't ignore the human element here. He's an anxious young dad, highly stressed about his family support, and he just wants to go home. That kind of psychosocial stress can sometimes actually mask early warning signs of physiological decline. But the absolute crucial complication to focus on here is high stoma output. Keep that in the back of your mind. All right, Section 3, Observations and Assessment. This is where the puzzle gets really tricky. When he was readmitted through the ED, his heart rate was up at a 115, blood pressure at 110/70. But look at these symptoms: pleuritic chest pain and a tender left calf. If you work in healthcare, alarm bells are probably ringing in your head for a deep vein thrombosis that's broken off into a pulmonary embolism, or PE. It's a textbook presentation. But wait, check out that last row. He also lost a massive 1 liter of watery stoma effluent in just 4 hours. I mean, that is a staggering amount of fluid and electrolytes rapidly flushing out of his body. And that massive fluid loss leads directly to this, a critical pathology alert. His potassium has completely plummeted to 2.8. Let's break down what that actually means. A normal potassium level should be between 3.5 and 5.0, so 2.8 is critically low. His magnesium is also low, sitting at 0.5. And to confirm the physiological impact of all this, his ECG shows sinus tachycardia with prominent U waves. U waves are a massive red flag. They tell us this severe hypokalemia is actively affecting his heart and could trigger a fatal arrhythmia at literally any second. So now we're staring down a massive diagnostic dilemma. On one side, we have super compelling evidence for PE, the pleuritic pain, the tender calf, the high clotting risk. On the other side, glaring evidence of a severe electrolyte crisis driven by massive fluid loss. So what do we treat? The clot or the crashing electrolytes? The terrifying reality is both of these can cause sudden cardiac arrest. Which brings us to Section 4, the deterioration event. Because at exactly 1400 hours, this goes from a theoretical dilemma to an absolute real-time emergency. Jaxson actually suffered a syncopal episode. He passed out while simply trying to walk to the bathroom. This directly demonstrates the real-world consequence of his condition. That slight exertion combined with massive intravascular volume depletion and an electrolyte crisis led straight to sudden circulatory collapse. His body literally could not maintain perfusion. And the numbers prove it. His blood pressure completely crashes to a perilous 85/40. He's actively in shock. At the same time, his heart rate spikes up to 135 beats per minute in a desperate attempt to compensate, and his oxygen saturation drops to 88% on room air. This deterioration is incredibly fast, it's severe, and it demands split-second decision-making. So what do we do? Let's jump to Section 5, the R in our isobar handover, recommendations and priority actions. Here are the exact priority actions required, in order. Step 1. Trigger a MET call, medical emergency team. You need advanced help at the bedside immediately. Step 2. Push an urgent fluid bolus to treat that circulatory collapse and drag that 85/40 blood pressure back up. Step 3. Start aggressive IV potassium and magnesium replacement using his existing PICC line. We absolutely have to stabilize his myocardium to prevent a lethal arrhythmia. And finally, step 4. Once he is hemodynamically stable, prep him for a CTPA to definitively rule that pulmonary embolism in or out. I'm going to leave you with this crucial question to challenge your own clinical biases. When a patient presents with classic PE symptoms, how quickly do you check their fluid loss? It is so easy to see pleuritic pain and a tender calf and immediately anchor on blood clot. But as Jackson's case shows us, if you don't look at the whole picture, like a liter of fluid lost from a stoma, you might entirely miss the electrolyte crisis that's literally about to stop their heart. Keep that in mind when differentiating overlapping, life-threatening conditions in your next handover. Trust the isobar structure, stay sharp out there, and thanks so much for joining me on this explainer.